you, Sinia. So we have our faculty for the day, Dr. L. Ramakrishnan, sir. Uh, he's a public health.
Sir, just a second. Let's introduce.
Yeah. So Dr. L. Ramakrishnan, sir, is a public health professional and vice president of Sathi, based in Chennai. He earned his doctorate in 2000 from the University of Texas at Austin, USA, and has worked in health and human rights non-profit settings in USA and India. As of 2018, his portfolio includes support to the M-Maitri Digital Health Initiative, to LGBTIQA+ inclusion programs, Empower Access and Vistara, Project Sambhuya, and Project Svetana. He was previously led programs on mainstreaming and decentralization of HIV/AIDS services, legal and social protection of PL-HIV, use of ICT to bridge information gaps, program evaluation and capacity building of implementers of health interventions. He is also involved in internal and external capacity building in areas of monitoring and evaluation, documentation, operations research, and gender and sexuality. Welcome you, sir. Thank you so much. Over to you, sir.
Yeah, thank you very much. Am I audible?
Yes, sir.
Okay, great. Just a second. Is my screen not visible?
Yes, it is.
Okay, thanks. So thank you very much for the introduction. The very fact that this introduction speaks about my portfolio as of 2018 really means I've been doing this session for quite a few years with Pallium India. Anyway, I'm very glad to be here with the folks who are attending this foundation course in palliative care. Would it actually be possible to have a quick round of introductions so I know, get to see and listen to some of y'all and your background? So maybe just your name, where you practice or where you work, and whether you have had any prior exposure to the LGBTQIA community. Could we have folks, maybe I can request you all to go ahead. Yeah. Could the facilitator actually call out names? Is that possible?
Sure, sir.
Yeah.
We'll start with Nancy. Nancy, can you please just briefly introduce yourself?
Nancy, I think you're on mute.
Hello?
Yes, Nancy, you're audible.
Yeah, I'm so sorry I missed. I was trying to connect the audio. Can you repeat the question?
Yes, Nancy,
Quick
can you just
introduction.
briefly introduce yourself?
Yes,
And
yes.
also tell us whether you had any exposure to the LGBTQA community academically or non-academic.
Sorry, sir, I couldn't hear the last part.
And also share whether you have had any exposure to the LGBTQA community in your professional or any other context, because this session is about LGBTQA.
Yes, sir. So first I'll begin by introducing myself. I am Ninsi Mariam Montli. I'm from Kerala, in Trivandrum specifically. I currently work as a junior psychologist in Pallium India. So I go to Pallium India on Saturdays. Apart from that, I also do a lot of part-time jobs related to the field of psychology and also arts. That's because I love art. And personally about me, I'm also a wheelchair user for the past 9 years now. Regarding my contact with people from this community, I haven't had real exposure, but I've recently come to know that some of my friends might be having partners who recognize themselves as queer. Okay, so apart from that, I haven't had meaningful conversations with them.
Thank you. How about Mona Verma?
I am from Delhi. I am tied up with India Cancer Society as a volunteer. I am volunteering since 7 years with Cope with Cancer and Tube Doctor. I never came across with any of such individual till now.
Okay, thank you. Karthik B, please. Please unmute.
Karthik, you are muted. Can you please unmute from your
Oh,
end?
sorry. Yeah. I'm Dr. Karthik from ESA Medical College, Coimbatore. I don't have any exposure to LGBTQ community.
Sheetal Thapa.
Sir, am I audible?
Yes.
Yeah. Sir, I'm Sheetal Thapa from Dehradun, like up north, and I haven't had any kind of exposure, but I've attended one kind of a seminar which was on transgenders empowerment in this place itself. And that was a very brief kind of this thing wherein I had actually met the people from that particular segment. And I have just been that much exposed. I'm otherwise an art teacher, and I am also into art practices in the, for the inclusion. That's been like a course that I'm going through, and currently I'm doing my PhD from IGNU in arts education, in the drawing painting, the that segment. So. And I've got some brief exposures on psychology also, but that's a little bit lesser than the other part. Thank you so much, sir.
Thank you so much. Shinad Kennedy.
Hello, I'm Sinead. I'm Irish, living in France. So I'm a palliative care volunteer in a palliative care unit in a hospital in Paris. I have exposure to people in the community from my family, friends, and work colleagues. But in my experience as a volunteer, it's not something that I'm sure I've met people from
Okay, thank you. Mohammed Akil, please. Mohammed Akil, could you unmute yourself or could you speak? Maybe you are not at your computer. Maybe we can come back to you. How about Aarti Nevla? Okay, if Aarti Nevla is not here, Mansi Shah, could you unmute yourself?
Hello, hi. Yes, sir. I'm sorry, I was late by 5 minutes. I missed your question. Can you please repeat your question?
It's an introduction to what you're doing and whether you've had any exposure to the LGBTIQA community professionally or personally. Please go ahead.
Okay, so I'm from Mumbai. I run this organization called Happy Feet Home. We work with children who live with life-shortening illnesses. So basically, thalassemia, HIV, cancer, these are the illnesses we work with. Personally, yes, I have come across the LGBTQIA plus community. We have a lot of my friends are from that community. I am known as an ally. I have attended a lot of their events and even participated in the Pride March and the the march against when the 377 was applied. I was there with them in Mumbai. One of our trustees in Happy Feet Home also represents that community, and he's in fact quite a well-known personality, celebrity kind of a thing, person in that community, in the LGBTQIA plus community. So yes, I've had a good exposure, or I understand.
Okay, thanks. That's awesome. Mr. Mohammed Akil, I see that your camera came on. Could you introduce yourself, please? You have to unmute yourself. Oh, I think we lost you again. How about Aarti Nevla? Please unmute yourself, ma'am. Okay, I think we've lost Aarti Nevla again. How about Sarah Stanley? Okay, if Sarah Stanley is not here, we move on to Pradeep Kumar Karumanchi. Please unmute yourself, sir. Okay, looks like a lot of people are connected, but not at the computer. Is there anyone else here? Is Sadhana Dandor there? Please go ahead. Unmute yourself. Yeah.
Okay. So I'm
Pradeep, we'll come back to you just a second. Pradeep, please give us a second. We'll come back to you. Sadhana ma'am, please go ahead.
Yeah, I'm Sadhana Dandore. I'm working in Happy Fit Home Foundation as a nurse.
Okay.
Okay.
And have you had exposure to the LGBTIQ community?
Sorry, I can't say anything about.
Okay. I'll take that as a no. Yeah. How about Pradeep? Can we get back to you? Yeah, go ahead. Unmute yourself, Pradeep. Pradeep Kumar, please unmute yourself. Okay, I think we are missing some people. Shahid Sheikh.
Yes, sir.
Please go ahead. Please go ahead with your introduction and tell us whether you've had any exposure to the LGBTQIA community. Please go ahead.
Hi, sir. So, my name is Shahid.
Yeah.
So, I work with Happy Feet Home. So, I work with Mansi Shah and Sadhana Randore Jharna, who are in this conference too. So we work with kids who are like suffering from life-threatening, life-shortening illnesses, and we try to provide them psychosocial educational support to them. And about LGBTQ, like I know I've known people who are my friend too, and who are also in this community too. And I have a bit of bits and pieces. I know like I know them in person, but also like right now when I got to know like okay, this topic is also getting here, so it was kind of, I was thinking what are we going to talk on this, as in, so they say I was just talking to my colleague right now also like as if anyone who is from LGBTQ, so if they have any diseases, like any sort of diseases, so how society is treating them, as in, like, it's supposedly if I have HIV and if and I'm gay, so how is I am getting portrayed by people, and ऐसे देखते कैसे है वो मुझे ऐसे. So that's something I was talking, and I'm very much interested like how this will, what are we going to talk on this thing. So yeah, thank you so much.
Thank you, Shahid. Very insightful. Tanya, are you online? Tanya Multani.
Tanya, can you please unmute from your end and speak? I think Tanya is not present.
Okay.
We can move on to Lakshana ma'am. Can you please?
Sure. Good afternoon, doctor. Good afternoon, team. My name is Lakshana. I'm from Bangalore. I work in marketing, but I'm interested in palliative care after the passing of my mother in December. I have queer friends, and that's about the extent of my exposure to LGBTQIA. Thank you.
Thanks. Sorry to hear of your mom.
Thank you.
Yeah.
Thank you, ma'am. Ashley, can you please unmute from your end and speak, sir?
Yes. Hi, I'm Ashley, and I work with an organization called Pathways. We help young adults who get out of institutions, for example, like orphanages, and help them with their mental health and getting a job, etc. I have a few friends and few encounters with the LGBTQI community. I've not faced any issue as such, but what concerns me or what I come across as being curious about is, even though like sometimes it's how do I put it? Sometimes even on our end and from their community end, it's probably neutral and there's no issues. But the problem is because they've been perceived as differently, they still have other issues because of the way they've been perceived. So that's not something that's similar to growing as a young child or something like that, being treated differently. So I'm pretty sure they have other problems they face because of this, because of the way they've been perceived.
Okay, thanks. Great point.
Yeah.
I think we can move to Rachel, ma'am. Rachel, ma'am, can you please unmute from your end and speak?
Good afternoon, sir. I am Rachel. I am a retired structural design engineer from the Department of Space. I am associated with Pallium India for the last 10 years. Actually, I had a friend of one of my children who used to come to our house. He was a male and he used to love dressing up like a woman, like a girl. So he used to come to our house because
like a woman?
yes.
Okay.
And because his parents were opposing, so he used to come here and he used to spend time with us. Now my children are not here, so I do not know where he is. He was studying in a professional college. So that's all I know, sir, about them, what they have in mind, their disturbances, how the community is not accepting them. So that's all.
I see. Okay, great. Thanks.
Thank you, ma'am. We can move to Sarna, ma'am. Sarna Jain. Ma'am, can you please unmute from your end and speak?
Hello.
Hi.
Hi, everyone. I'm Sharna and I'm from Happy Feet Home. We work with children living with life-threatening, life-limiting illnesses like HIV, thalassemia major, and cancer. Sometime back, my colleague Shahid introduced himself. So with respect to LGBTQI, I have a lot of friends who are from this community. And I don't place anyone in this binary of male and female. This binary division of sex where you call one male and one female. It should be free flowing according to me. And anyone who wants to express themselves as they wish, they should have the right and freedom to do so.
Great. Thank you.
Thank you, ma'am. I think we can move to Tanya, ma'am. Tanya, can you please unmute from your end and speak? Tanya is facing issues with connecting audio.
Is anyone left?
Yeah.
I think two Pradeeps are left and Santosh.
Mohini, ma'am, have you introduced yourself? Mohini, ma'am, can you please unmute from your end? Santosh, sir.
Hello. Yeah. Someone, yeah, Tanya says, I'm sorry, I'm outside. I couldn't talk due to network issue. That's okay. Yeah. Thank you. Anyone else? Maybe you can just unmute and go ahead and introduce yourself. Yeah.
I have already spoken, but
Okay.
can I ask a question?
Please.
So like I said, I have a lot of friends from the LGBTQIA plus community, I have one issue. My issue is when we address them as a different community. It should all come under human rights and not a different set of rights, because at the end of the day, we're all humans. Why I'm a little curious, like Shahid also mentioned, my colleague. I'm a little curious. I got very curious when I saw that our last session is on this topic, and I'm very curious to understand why is it different and why should it be treated differently. So I'm really looking forward to what comes out of this session.
Okay, fair enough. And thank you for raising that. I think we can probably, in the interest of time, move on to the actual presentation. And yeah. So essentially, what the session was focused on was, in palliative care, normally there is a certain understanding of sources of support for a person who needs palliative care. That source of support could be an external care provider, it can be a member of the family, it could be an institution, etc. But very, very briefly, if you just want a take-home point here, a lot of people from the LGBTIQA community do not have a support system. Many of them are estranged from their natal families. If there is somebody who's actually in a relationship with a same gender partner or a trans partner, it's very difficult even within their natal family to come out and say this. And very often they are afraid of being stigmatized and discriminated against, even within the healthcare system. So very often you don't know who are the people in their life who might be, a romantic partner or somebody who can potentially provide some kind of support. And as a healthcare provider, if you look at all of medicine, look at all of the health sciences, they are generally cast, the education and the thinking is cast in a framework which is very binary, which assumes heterosexuality. You assume that every man there has or had a wife, and vice versa, unless they come out and say that they're single or they're widowed. So very often it doesn't even cross the mind of people who are providing palliative care or other forms of healthcare to explore up their the personal situation of the person who's the care seeker. And hence the purpose of the session is to essentially bring the issue of people with alternative genders and sexualities and sex characteristics on the radar, so you can make sure that you are providing sensitive care, asking questions, even doing physical examinations if necessary, in a way that does not traumatize the individual and that actually enables them to share openly, because this is also an integral part of the whole care framework. Mansi, did I summarize?
Yes.
Yeah. Okay.
Very much. Thank you.
So good. So I also, even though many of you actually have had exposure to the community, you've talked about someone, a member of your board or trustees being from the community or having friends from the community. There are, in previous sessions like this, quite a few healthcare providers who have actually not had any exposure to the community, except maybe trans women begging at road signals or some such encounter. And very often for a lot of people, the distinction between who's transgender and who is LGBTQIA is lost. Even within the healthcare settings, I have engaged with medical doctors who are in the policy making capacity in the Ministry of Health and Family Welfare, Government of India, and they themselves are confused between who is transgender and who's intersex. So there is quite a bit of ignorance in the medical fraternity, in medical education, and in healthcare policy making. So some of the work that we are engaged in is actually to reform the medical curriculum, because many of the textbooks that are used in India, this goes true for nursing curriculum as well, is outdated. The books have just been reprinted without actually amending or updated the content. So even now in 2021 edition, 2022 edition of the standard MBBS textbooks and MD textbooks in fields as diverse as pediatrics, obstetrics and gynecology, forensic medicine, psychiatry, etc., you have a lot of misinformation about the LGBTIQA community. So this particular session is a small attempt to try and provide clarity on the basics, address a few misconceptions, and then hone in on what you as a potential or existing palliative care provider need to keep in mind. And for that, we'll be looking at a few best practices that have been published in palliative care journals to see what of that is applicable. And the crux of this entire session is for me to hear from you all, both in the beginning, which you've already shared, most of you have shared, but also after the session, I'd like you all to reflect a little bit on how you might look at a person who is in need of care differently. It may not always be a case that a person who's seeking care will actually come out and tell you that they are from the community because of having experienced many negative things, even in a healthcare context. So how can you sensitively explore, ask questions, etc.? Okay, so I'm going to do a very rapid 101. So this part is about sexuality, and I show you that there are three overlapping circles. One is sexual orientation, which is who one is attracted to. There's a behavior, which is who one is having, sexual relationships with. And the third one is identity, is how a person identifies, is gay or lesbian or bisexual. Again, I'm talking specifically about sexual orientation and not about gender identity. So I'm not talking about transgender people at the moment. Now, the reason these three circles are overlapping, but not necessarily all, exactly concordant with each other, is that sometimes orientation, behavior, and identity do not correspond to each other. Imagine a person who is a woman who is attracted to only other women, and in a culture and a society and a family which was open, she might come out and identify as lesbian. But in a society or a community or a family that is very conservative, even if they know that this is her orientation, they would not encourage her being visible or out. And in many cases, we see in the Indian context, such women are forcibly married off to men by their parents, right? So in such a case, her orientation in this hypothetical scenario would be a woman attracted to other women, but her behavior, if she is from a very conservative family or has been forced to marry a man, may not correspond to her orientation. She may be forced to engage sexually with a man, okay? And she may or may not be in a position where she can actually come out as lesbian, because that itself could entail a lot of stigma and discrimination. So there are all these terms of sexual identities, and I'm going to do a rapid fire a listing of these. Many of these are going to be familiar to you, so think of it as a revision. So gay is an identity which corresponds to a primary or an exclusive attraction to the same gender, plus lack of attraction to another gender. So if a man is attracted to another man, you can't say the person is gay unless the person is also not attracted to women. Bisexuality, in the healthcare, there are a lot of misconceptions that someone who is bisexual is someone who's engaged sexually with people of more than one gender. This is not true. It is only about who you're attracted to, and it need not be 50-50. It can be 60-40, 70-30, etc., etc. Just like you presumably as a heterosexual person knew of your attraction even when you were not in a relationship or not married, you knew who you were attracted to. Similarly, a bisexual person knows who they're attracted to, regardless of whether they are in a relationship with somebody of a particular gender. And this additional caveat is, if the person is in a relationship with somebody of another gender, you can't necessarily infer their sexual orientation. So you may have a man in a relationship with a man. It does not necessarily mean that both of them are gay. One could be bi, the other could be gay, both of them could be bisexual, etc., etc. Heterosexuality, or straight as we say, talks about an identity corresponding to primary or exclusively attraction to the other gender, coupled with lack of attraction to the same gender. Lesbian is sort of is a term that women who are same gender attracted use, and some lesbian women also use the term gay to describe themselves. Pansexual is a term similar to bisexual, but often people who identify as pansexual say that I'm attracted to people regardless of what their gender is. There are other characteristics of the people that attract me and not necessarily their gender. Asexuality is a term referring to lack of interest in engaging sexually with somebody else. Asexuality does not mean the person is not having sex. This is about desire. So an asexual person is different from a celibate person. So a gay or bisexual or heterosexual or lesbian person may choose to be celibate, but that's not saying anything about whether their attraction exists or not and who that attraction is. So an asexual person is someone who is not attracted sexually. Queer was originally a gali, a pejorative term, but now it's been used by the community as an inclusive umbrella term. So there are people who are gay or bi or a lesbian or pansexual who may call themselves queer. There are even trans people who may call themselves queer. So queer is kind of used as an umbrella term. Queer is also used as a term by people who feel that their identity does not fit neatly into one of the other labels. Okay, so before I move on to gender, any quick questions around sexual orientation, sexual behavior, or sexual identity? Very briefly, orientation is who you're attracted to, behavior is who you engage with, and identity is who you identify as. So I'm going to stop screen sharing, take a couple of minutes to answer any questions that you may have at this stage before moving on. Just feel
Hi,
free
sir.
to unmute.
Can
Yeah,
I ask?
Sahil. Go
Sir,
ahead.
I wanted to ask if you are saying queer, so is it just like we are talking about gender, or is it about like we are different, or like socially we are saying like we are different than other? I think unorthodox or orthodox. How are you
Yeah.
differentiate? Is it something?
So I think it's an excellent question. In this narrow context, I'm defining as somebody who's queer, as somebody who is not heterosexual, and somebody who's not cisgender. And what is cisgender is something I'll come to very soon. But basically someone who's not straight, someone who's not cis. Now, there is a broader cultural definition of queer where some people use the word queer to refer to the fact that they do not conform to many of society's norms, going beyond sexuality, going beyond gender. But for right now, I'm keeping this as a rather sort of a clinical definition of queer as an umbrella term for people of diverse sexualities and diverse genders. Okay. And we
Okay,
can
sir.
discuss the subtleties of queer later, but yeah, broadly, I'm using it in this very specific context. Yeah. Any other,
Okay,
and we
okay.
have time for one more question before getting on to gender. Yeah. Anyone else? Okay, then I'm moving on. Okay, so now I'm going to gender and gender identity. And a lot of us, especially if we have studied social sciences, have been told that, sex is biological and gender is social. And sure enough, if you look at the World Health Organization's definition of gender, it talks about socially constructed roles, behaviors, activities, and attributes that are different, that a specific society considers appropriate for men and women. So, for example, a person who is born with a penis and a scrotum is announced by the doctor delivering the baby, saying this is a boy. And then with that come all the expectations during child rearing of how a boy is supposed to be, how a girl is supposed to be, how a boy is not supposed to be. So things like can be as simplistic as boys don't cry, or women are expected to be much more domestic, much more sedate, less interested in outdoor activities, less aggressive, more likely to, compromise, if you will. So there are all these stereotypes. Some of them are also very culturally variable. So wearing something like a sarong or a lungi or a dhoti is something which men in Asia or South Asia or Southeast Asia wear, but apart from Scotland, nowhere else in the global north is something like a lungi or a dhoti considered appropriate wear for a man. So there are aspects of clothing, there are aspects of gesticulation, hand movements, the tonality in your voice, the kind of how you project yourself, how you make eye contact, how you sit spreading your legs or not, that society considers appropriate for a particular gender. So a person who is, let's say, a child who was assigned male, and that child is behaving in school in a way that is considered girly or effeminate, is a child that ends up getting bullied and teased a lot in school. So such child may or may not be gay, may or may not be transgender, may or may not be of any bisexual or any other orientation, but still the fact that that child is expressing their gender in a way that boys are not supposed to behave like, or in terms of choice of color, whatever it is, the child can actually be teased and bullied. And some of this teasing and bullying can leave lifelong scars in terms of the person's trauma and how that person interacts with the world. Now, apart from gender, which we've talked about as being social, there is actually an internal sense of gender that every individual has. And as per the American Psychiatric Association, gender identity is a person's deeply felt inner sense of being a boy or a man or male, a girl, a woman or female, or a person's deeply felt inherent sense of being neither boy nor girl, or being both boy or girl. And so typically a child who's assigned male at birth, who is brought up as a boy, thinks of themselves as a boy. But there may be some such children who think of themselves as girls. So in such a case, that person's gender identity is different from the socially assigned gender, which in turn is based on the biologically assigned sex. So if the gender identity does not correspond to the gender or social gender, you refer to the person as transgender. If the gender identity corresponds to the social gender or matches, you refer to the person as cisgender. So I'm imagining that the majority of people in this room do consider themselves as the same gender identity as the social gender. So most of the people here would be cisgender. Maybe there are some people who are not cisgender, in which case they would be transgender. So, so basically, transgender is gender identity which is contrary to the gender assigned at birth based on biological sex. So it's a boy or it's a girl. The assumption is that that boy or girl is, biologically male and female respectively, and they are assigned a particular gender. And if they have a different gender identity, then they're transgender. If not, they're cisgender. Now, within transgender individuals, you have folks who consider themselves to be binary. So a child who's assigned male at birth, who identifies as a girl or woman, a person who is assigned female at birth, who considers themselves a man or a boy, would be binary because they consider themselves to be of the opposite gender when it comes to their gender identity. But if someone, a transgender individual, does not consider themselves to be a boy or a girl or a man or a woman, such a transgender identity is considered non-binary. Okay, and in some communities, traditional communities in India, like the Tirunangai or the Hijra or Kinnar community, people will say they belong to the third gender or Tritiya Panthi, etc. So that is a particular case of a cultural non-binary identity. It doesn't mean that all trans people consider themselves as the third gender. Some of them do. Okay. The other aspect is, earlier we spoke about sexual orientation, that is who someone's attracted to. You have to keep in mind that gender identity is independent of sexual orientation. So a trans woman, that is a person who is assigned male at birth, who identifies as a woman, may or may not be attracted to men, may or may not be attracted to women. The person could be attracted to men or women or both or neither, could be attracted to other trans people, could be attracted to cis people, could be attracted to all of the above, or could even be asexual. Okay, so gender identity and sexual orientation are independent of each other. And this is very confusing because when you meet visible, trans women, the majority of them will say they are attracted to men. And the majority of trans men will say they are attracted to women. But this may be the majority, but there's still 8 to 10% or more of people who are actually attracted to the same gender or to multiple genders. Now, in India, there are a lot of terms for trans people. Rupi Manvi is from Maite, which is the language of Manipur. Hijra and Kinnar. Hijra is a term, I guess, originally Arabic and Urdu. Kinnar is more of a Hindi/Sanskrit term. Tirunangai is a term for a trans woman in Tamil. Tirunambi for a trans man in Tamil. Arvani is an old Tamil term for a trans woman. Then you have terms like gender fluid, agender, non-binary. All of these are different terms. Now, the importance of talking about these is that in India, if you look at overall society's recognition of the LGBTIQ community, many people in the country would have seen the Hijra or Kinnar community, and they at least acknowledge that the Hijra or Kinnar community is part of Indian culture because there are references to Hijras in history and mythology and religion, etc. But very often the common person in India has not heard of terms like gay, lesbian, or bisexual, because these are one of the things is that they're English words. But this contributes to a mistaken understanding that people who are LGB are necessarily people who are westernized, who are rebelling against Indian culture and tradition, and so on and so forth, which adds to some stigma and discrimination against the community. But the point I want to make here is someone who's gay, lesbian, or bisexual, attracted to the same gender or multiple genders, is very much as Indian as people who are transgender. It's just that because they're not so visible, many of them have chosen to be invisible to avoid social stigma, unlike trans people for whom invisibility may not always be an option. Okay, so trans people are very much as Indian as gay, lesbian, and bisexual, or asexual, or non-binary people, but whether people come out and identify is a different thing. Okay, then two related terms very quickly is how the person expresses themselves, which is called gender expression. Earlier on, I gave you an example of somebody who's assigned male at birth, who acts in a feminine or effeminate way. Such person is said to have, such a child is said to have a gender non-conforming expression or non-conforming gender expression. So a male child, a biologically quote unquote male child who's acting girly is expressing their gender in a way that is not consistent with the assigned gender. And culturally, what you expect is that the assigned gender will correspond to the social gender, which will correspond to the gender identity. But as we've seen in the last 3 slides, the 3 of them don't necessarily match with each other. So you may have somebody who is who's assigned female, but has a masculine gender expression, but whose gender identity may or may not be that of a trans person. So expecting all of these things to line up is the issue. So gender non-conformity is basically someone whose gender expression does not correspond to the socially assigned gender's expression. So very often you use the term gender non-conformity in the case of children, but to point out that children who are gender non-conforming or whose gender expression is non-conforming face bullying and ragging and violence, regardless of how they may eventually identify as an adult, as being on the LGBTIQA spectrum. And if we are to make sure that children are able to complete school and have as many opportunities to study and work as everyone else, it is imperative for people who run schools and teach in schools and administer schools to watch out for children who are being bullied, because bullying is a high risk factor for dropouts. And we have data from our own projects of about 13,000 people, of which nearly 30 to 40 people, the 40% dropped out by 5th standard because of the bullying that they faced. So the bottom line of this is that gender nonconformity is a risk factor for dropping out and a risk factor for violence and bullying and teasing. So one thing to remember is a child who's gender nonconforming, as an adult, you cannot predict that they will necessarily identify one way. They may identify as straight or gay or lesbian or transgender. So you can't necessarily infer the sexual orientation or gender identity of an adult from how the child is. Okay. However, if you ask transgender adults, the majority of them have reported being gender non-conforming as children. And okay, I think I will again stop here, pause here and see if there are any questions, because I went through a lot of material very rapidly. So any questions about transgender that were addressed or not addressed during this session so far, or any questions you may have? Hands up, please go ahead, or you don't have to raise your hand, just unmute and speak or ask. Sheetal? Yeah. I can't hear you. We're not able to hear you. Hello, is there something wrong with you?
You are not audible, Sheetal.
Yeah. Go ahead. Sheetal, unfortunately, I can still not hear you. Yeah, go ahead.
Sheetal, ma'am, can you please check if your audio is connected?
And if it's not connected, type your question in the chat, please.
Yes, sir.
You are audible now.
I'm audible now? Okay. I had actually put so just wanted to ask, because you have mentioned a lot of things, a lot of more details probably, which few things, many of them I did not know. Sir, I also kind of counsel the school students in some which way. Many a times the parents come up with a question like, whether they're saying like, if they are not having any problem in those terms. So is there any kind of a test or something that I can recommend them, or we can look through, which helps them to know the orientation of the child, like, because you mentioned the word like those specific phrases, like those children tend to be bullied, or they stay aloof, or whatever those. So is there some way of finding out their orientation when they are in school, or any kind of tests that are there? Because sometimes some problems we can count in that term also. I don't know if I'm taking it in the topic or is it away.
No, it's a valid point. So there really is not a test one can do to determine if someone, there's not a physical test or a biochemical test or a physiological test one can do.
Maybe a psychological test or something, sir. I don't know.
No, to determine whether one is of a different sexual orientation, or if someone is of a different gender identity. But
yes,
a mental health professional who creates a safe environment can ask the child, perhaps away from the parents, because the parents may be an inhibiting factor, about how the child feels in terms of how they perceive themselves, and maybe the child is a little bit older, ask about who they are attracted to. But there is no objective test. There are psychometric tests given to people who are transgender, like the Rorschach test that I'm sure you heard of as a clinician, that try to demarcate the gender associated characteristics of a client. But there is a lot of evidence that these are not necessarily very reliable. But to very succinctly answer you, the best answer, the best test is ask the child in a safe environment of like how the child feels in terms of who they are attracted to or how they think of themselves. But I want to caution here that when I talked about bullying, etc., a lot of the bullying is based on the child's gender expression. Like a male child, quote unquote, male child being feminine, or a quote unquote female child being masculine. Such a child may or may not actually have examined or introspected in terms of their own sexual orientation or gender identity. Some may have, some may not have. So it's, even if you ask, you may or may not get an answer, because a child who's gender non-conforming may not necessarily be at that age where they can think about their sexuality and gender. Yeah. And a person has asked, why is it even now, it's asked in our applications, female or male, how that people with different identities identify themselves. Yeah, there are 2 points here. One is, when in our applications, if they say female or male, are they referring to sex or are they referring to gender? Second is, of course, it is looking at the world only in black and white, 1 or 0, binary, female or male. So people who do not identify in either box will have a struggle filling that box. So a lot of the government application forms now actually have a third box that says transgender or other. But yes, we have a long way to go. And even if you go to hospitals, the forms always say female or male, the wards are always male or female, the bathrooms are always male or female. And this causes a lot of problems for people who do not identify within the binary. I have time for one more question before we go on. Anyone? Okay, so I'm just going back. Now I'm skipping one slide called gender dysphoria. I will come back to it if there are questions about it. Actually, why not? I'll just come back to it. So there are some individuals, when I say people have a gender identity which is transgender, I'm talking about, for example, a child who's assigned male biologically, but who thinks of themselves as a girl, or a child who's assigned female biologically, but thinks of themselves as a boy. Some such children are very, very uncomfortable with how people around perceive this child. So you may have a male assigned child who actually says, I don't want my penis, and who prefers not to stand and urinate, who wants to sit down and urinate, etc. So this is actually a term in psychiatry called gender dysphoria, which is an acute discomfort with their body. And accompanying this discomfort is also a desire to change their body. So such gender dysphoria may manifest at a very young age, or it may manifest during adolescence, where a female assigned child who starts developing breasts and starts menstruating is very, very uncomfortable with those physiological processes, and is facing a lot of mental health stressors because of that. So people with the strong sense of discomfort with their body are those trans people who are most likely to want to change their body through hormones or surgery or other means. So it's not a given that everybody who's transgender desires to change their body. Some of them do, and these are the people who have this acute discomfort with their body, which is called gender dysphoria. And if somebody wants to change their body in the Indian context through hormones or surgery, typically you have to be 18 and above. If you're below 18, you need to have your parental assent. Second is, before getting on hormones or before opting for surgery, you need to have a psychiatrist, or in some cases a clinical psychologist, say that, certify that you have gender dysphoria. Now, gender dysphoria is the terminology that you'll find in this in this book called DSM, Diagnostic and Statistical Manual. If you look at ICD, which is the WHO book, in ICD-11, there is a term called gender incongruence. So these are some of the technical terminology. Gender dysphoria is coined by the American Psychiatric Association. Gender incongruence is by the WHO. And the old name for gender incongruence is gender identity disorder. But nowadays, having gender incongruence, having a different gender identity than the social gender, is no longer considered a disorder. In 2018, WHO changed it. In 2022, India adopted ICD-11. And yeah, so this is about gender dysphoria. Now I'm moving to sex. Now, when we talk about sex, the biological sex, everybody thinks they know what is sex. So you ask a person, the person is going to say, a person who has these body parts, a penis and a scrotum, internally a prostate, etc., is male. A person with a vulva, clitoris, uterus, ovaries, etc., is a female. Or somebody who's had some high school biology may tell you that a male is somebody who has XY sex chromosomes, and a female is somebody who has XX chromosomes. Or a person may adopt the approach of saying a male is somebody who has much more testosterone hormone and much less estrogens, and a female is somebody who has more estrogens than androgens, of which testosterone is an example. So these are all different ways in which biological sex is classified, either based on chromosomes or based on the proportion of the quote-unquote male and female hormones, or based on the internal body parts or the external body parts. And there's an assumption here. Just like we said, sex is assumed to correspond to social gender, which is assumed to correspond to gender identity. Here we assume in the area of sex that a person with XY is going to grow up to be an individual with more testosterone, and is going to grow up to have these body parts, or have all of these body parts right from the beginning, right? So this assumption that chromosomes align with hormones, align with anatomy, align with morphology, is itself an assumption which is not always valid. Give you an example. Here are examples, the figure on the top right, of genitalia of children that are all XY. So as per the chromosomal sex, all of them have XY, which is supposed to be male. But some of them have genitalia that look completely female. Some of them have genitalia that look very male, and you have a whole range of intermediate conditions. So here is a case where the chromosome the configuration of sex chromosomes, which is XY, do not align with the external body parts. So you may have a child with XY, but has external genitalia that look female. So when such a child is born, the doctor will say this is a girl, and the parents will raise the child as a girl, but find out at a particular age that the child is not menstruating or not developing breasts, or is and then the parents get panicky and take the child to a doctor where they may do a karyotype test of the cell and find out that the child has XY chromosomes. So this is one of many examples of what are called intersex variations. And here again, there is a very strong confusion even within the medical community between intersex and transgender. We are not talking about gender identity or socially assigned gender, where we have the categories cisgender and transgender. We're talking about biological sex, where the hormones, the external body parts, the internal body parts, the chromosomes don't all line up. So there are certain other intersex variations where, for example, you may have an individual with 2 X and 1 Y chromosome, or a single X chromosome, etc. In this particular case of these graded 6 types of genitals, these are all one single condition called androgen insensitivity syndrome, AIS. And this basically when the sperm and the egg fuse and the embryo is developing in the mother's womb, the developing embryo, if it does not respond at all to androgens, to the male hormones, then the child will, even though it has XY chromosomes, will develop into the default pathway of female. And this is called complete androgen insensitivity. Then if the embryo is only partially responding to androgens, depending on how much it responds to androgens, you can have any one of these other types. So the more penis-like, the more the embryo is responding to the male hormone during the 9 months of development. So originally, medical science classified all of these as disorders, and there is a term you will still find in the medical textbooks that says disorders of sexual development, or DSD. Nowadays, they've realized that these are much more common than they were thought to be. In fact, almost 1 in 100 individuals has some kind of an intersex variation. So now the abbreviation continues to be DSD, but the expansion has changed to differences in sexual development. And also the guidance in the field of pediatrics and pediatric urology and pediatric endocrinology is that if a child is born with body parts that are intermediate, don't do anything, don't do any surgery. The typical reaction of the doctors and sometimes the parents is to operate on the newborn infant to make their genitals look typically male or typically female. But there have been studies of such children who have grown up into adults who've been completely traumatized by these surgeries. So in India, in Tamil Nadu, there's a high court order, and there's also a government order from the Department of Health and Family Welfare saying that such surgeries should not be done unless there is a life-threatening condition. So sometimes there are life-threatening conditions where not only is the genitals ambiguous, but the urethral opening may be closed and the child cannot urinate. So in such very rare cases, you may need to do a surgery, but otherwise such surgeries do not need to be done. So this entire thing that I've talked about is sex characteristics, particularly intersex characteristics. So far I've talked about the 101 of what is sexual orientation, where you have heterosexual, bisexual, homosexual, including gay, lesbian, asexual. I talked about gender identity, which is cisgender and transgender. And within transgender, we have, binary and non-binary. Now I've talked about intersex variations. Now so these are all very different things. Now, why are we discussing this in this class on palliative care? Individuals that differ from either the sexual norm of male and female, or the sexual orientation norm of heterosexual, or the gender identity norm of cisgender, face a lot of problems in society. A lot of people will say, oh, this is not natural, this is not in our culture. But actually, there's a lot of, if you are a historian or an archaeologist, you will find that there are several depictions in sculptures and mythology, etc., of same-sex behavior or transgender appearing figures like Ardhanarishwara, which, is bilateral androgyne. One half looks male, one half looks female. Also in communities that have been relatively untouched by colonialism, whether it is British colonialism or even Hindu colonialism, like some of the communities in Manipur, having a trans child is actually considered to be a blessing to the family, and such children are treated with a lot of respect. So the fact that this is not found in our culture is a myth. Also, there are people, especially healthcare providers and doctors, who will say this is not natural. But we have, examples from nearly 400 species of non-human animals, including mammals, reptiles, fish, birds, and insects, that actually show that these differences in orientation as well as gender are found in a variety of species. So here are many examples of, here we have dolphins, we have birds, including penguins and swans, and we have chimpanzees, that, where you have individuals of the same sex actually pairing for a long time. Sometimes these birds will steal eggs from another nest and raise these as chicks. A lot of examples there are there. So the point of these two slides is to say that the argument of not in our culture or unnatural are both wrong. But what are the problems faced by the LGBTQIA community? Society as a whole enforces the idea that people should be either men or women. Men should be attracted to women and vice versa. A man should be masculine, a woman should be feminine. A man should be aggressive, a woman should be more compliant. Everybody should get married and have children, particularly male children. These are all the problems imposed by society and family that impact individuals from the community. Also, as I said earlier, we have bullying and other abuse by peers, especially for gender non-conforming children. This can lead to suicidal ideation. Also, there are unethical healthcare providers who tell the parents that, parents might take their gender non-conforming child to the doctor and say, doctor, my child is abnormal, please cure my child. And doctors will take a lot of money and pump the child with antidepressants or which kill libido, or they may give electroshock or some other kind of unethical and unscientific modality to promise the parents to change their child from gay to straight or from transgender to cisgender. Now in India, Kerala and Tamil Nadu are the two states where there are high court orders banning this kind of practice called conversion therapy. And very recently, the National Medical Council has sent a circular to all the state medical councils saying that if any doctor is practicing this kind of conversion therapy, it will be considered professional misconduct and they are liable to have their MBBS license revoked or MD license revoked. Nevertheless, these practices still go on. All of these issues, heterosexism is the belief that, being heterosexual is the only right and proper way to be. And rigid gender norms, this is how men will behave, this is how women will behave. All of these lead to thoughts of, we can look at all of this. So the prejudice from society that we call homophobia, biphobia, and transphobia, depending on whether it is directed against gay and lesbian people, bisexual people, or trans people, difficulty in coming out, stigma and discrimination, and social isolation, feeling that I'm the only person like this in the world or in my class. All of these from a mental health perspective can lead to low self-esteem, depression, anxiety, eating problems, substance use, suicidal ideation, self-harm, etc. Here, SOGI, SO is sexual orientation, GI is gender identity, and E is expression, so gender identity and expression, and SC is sex characteristics. So SO refers to gay, lesbian, bisexual, GI refers to transgender and cisgender, gender expression refers to people who are conforming or not conforming, and sex characteristics refer to people with intersex or without intersex variations. Yeah. So there are quantitative data from other countries. For example, if you look at the bar graphs in the top right, both among adolescent boys and girls, contrasted with gay, bisexual, and lesbian, contrasted with non-gay, lesbian, or bisexual, you have the gay, lesbian, bisexual having higher thoughts of suicide and higher rates of attempted suicide. Okay, so for example, if you look, lesbian and bisexual adolescent girls, 52% have attempted suicide, whereas 24.8% of those who are not lesbian or bisexual and who are adolescent girls have attempted suicide. This is again a North American study published in the Journal of Adolescent Health. For transgender people, the data are even more stark. And if you look at all of these things, 47% have attempted suicide, 19% were refused medical care, 41% can't change their gender or their identities, and so on and so forth. So see, 19% were refused medical care. And this actually includes palliative care because of the attitudes of the providers. So, and if you look at the educational outcomes, gender non-conforming children who face verbal, physical, emotional, sexual violence feel isolated, feel like they do not belong, have anxiety and depression, and even suicidal ideation. And all of this, if it doesn't lead to suicides, leads to fallen grades, loss of educational aspiration, increased absenteeism, and ultimately dropout from schools. Very quickly, what does the law say? Earlier, someone talked about Section 377. So in summary, since September 2018, it is no longer a crime to be in a relationship of the same with someone of the same sex. So until 2018, we had Section 377 of the Indian Penal Code that said that if you were in a same-sex relationship, you were a criminal, regardless of whether your relationship was consensual or non-consensual, whether it was with an adult or with a child. But in September 2018, the Supreme Court said, as long as you're an adult and in a consensual relationship with another adult, your sexual orientation or sexual behavior or gender identity do not matter. Also, since 2014, there was another Supreme Court verdict, which specifically laid out the rights of transgender people, including the fact that a trans person can identify as a man or woman, in other words, binary or non-binary, and should not be forced by the government or authorities to show proof of having had hormone therapy or surgery. Even without hormone therapy or surgery, they can self-identify as transgender. Now, this conversion therapy that I mentioned earlier has been banned by Madras High Court, and after that by Kerala High Court. And there's also the National Medical Commission directive. Here is an important quote by Dr. K.S. Jacob, who is now retired, but he was the head of Department of Psychiatry, CMC Vellore, who has been writing since 2009 to fellow psychiatrists about not doing conversion therapy, saying it's not scientific or ethical. And now, based on these high court verdicts, it's not legal either. So if we are talking about palliative care now, and these are the last few slides before we get into discussion, it's 408. Okay. So estrangement from natal families. A lot of people, especially trans people, find that they cannot stay at home anymore, or even LGBT people feel that to escape the pressure of marriage, they have to run away from home or leave home. Estranged from their birth families. Next is non-recognition of relationships with those of same gender. During COVID time, there's a couple that I know, two men who are in their late 30s. Both of them have been in a relationship with each other for nearly 17 years. But when one of them was admitted with acute COVID, and the decisions about putting that person in acute care and the kind of treatment modalities, they were refusing to consult the partner. They only said, bring your family members. And the family members who knew about this person, sexuality, had completely cut him off from the family. So this led to what could have been, a fatal consequence. But fortunately, the person recovered and the couple is back together. In good health, thankfully. But this non-recognition of relationships also very much impacts healthcare, because sometimes you need people to make medical decisions for you. And in India, the 2017 Indian Mental Health Care Act is the only the only piece of legislation that actually allows an individual to nominate somebody other than a blood relative or a legally married spouse to make medical decisions for them. But there is no relationship recognized other than man-woman relationship in the law, which has implications both for family and healthcare. Historically, there's been a lot of indifference or hostility in healthcare settings. 2 months ago, there was an individual who got raped by men, and the person went to an HIV clinic in Coimbatore in Tamil Nadu, where the ART doctor said, as a man, how can you get raped? You must have really enjoyed it and had sex with 4 or 5 men. And this doctor refused to even give the person post-exposure prophylaxis, which is a medicine you give within 72 hours to prevent the person from getting infected by HIV. So sometimes the barrier is hostility, sometimes the barrier is just lack of recognition and assumptions that everybody is heterosexual. And these assumptions are also there within the palliative care community, which Pallium India is very laudably trying to change, which is why Pallium India has been hosting sessions like this for many years now. So here are some best practices for the palliative care fraternity. So you create a space which is safe for the person to disclose their sexual orientation or gender identity or sex characteristics. Maybe it requires not having the parents around. Maybe it also requires not having the legal wife or husband around, because maybe the person was forced into marriage and the person has not spoken about their sexual orientation or gender identity even to their wife or husband. Second is, don't assume the person's sexual orientation or gender identity based on how they look. You have to utilize respectful and sensitive ways to elicit sexual orientation and gender identity information. And if you do these simple things, there have been data showing that the patients have greater comfort level, higher satisfaction with healthcare, improved alignment between the patient and the caregiver and provider, better quality of life in general for the LGBTQ patients and their caregivers. Okay, and this is a study that came from a journal of oncological nursing. It was published in 2018. Yeah, palliative and end-of-life care for LGBT cancer patients and their caregivers. So we are used to dividing the world into, gay and straight and cancer and no cancer. All of these interact with each other. So there may be people from the LGBT community who are living with a different life-threatening illness. It may be cancer, it may be a blood disorder, it could be untreated HIV, which can progress to AIDS, etc., etc. Then, okay, here is another paper from, another quote from the same journal, where they have recommended understand the lived experience of the patients through their experiences of multiple external and internal stressors, implicit and explicit bias, oppressive and discriminatory encounters, and destructive health systems. You ask them, who, if you had to choose a person to be with you at this time, who would it be? And don't assume it will be a legally married husband or wife or a parent or a sibling or a child. It could be someone else. And if possible, and if your country's law allows it, for advanced care planning, how can you include these non-traditional partners also, partners not recognized by law, in decision making? As of now, only if the person is having a mental health issue can they designate a non-blood relative or spouse, as I said. And there's a lot of advocacy happening in the country right now to be able to include people who are, same gender partners. And this is actually the core of the current Supreme Court hearings. You may have heard a lot of press and media talking about gay marriage, etc. At the heart of that is really a demand, not of living together as husband and husband or wife and wife, but actually have somebody whom you can designate to take care of you or be taken care of, someone you can designate for childcare, for child custody, for inheritance, etc., etc. Here is an article from the journal Palliative Care and Social Practice, which gives you some more best practices. So if you are required to do a physical examination, you ask consent, and this holds true for every patient, whether or not they are LGBTIQ. But you ask them, are you comfortable being touched here? Are you comfortable exposing this body part? Maybe you need to examine a body part for rashes. Maybe you need to look to see if there's some infection, if there's some phimosis, something. You may have to do a physical examination, but if the patient is able to give consent, please ask for consent. Also, an individual who's transgender or gender non-conforming may or may not have the body parts you expect. The person may have not undergone full surgery. You may have somebody who's a trans man who has removed his breasts, but has not constructed a penis, but actually has a vulva and a uterus. So asking them about their body parts also can result in a lot of, difficult reactions from the patient. So please ask them, you can even ask them, are you comfortable with this? What do you call this body part? And openly discuss the purpose of doing the examination. You shouldn't be doing a physical examination because of a morbid curiosity to see what is underneath their pants or inside their skirt. It should be done only when necessary And you can actually allow the patients to teach providers about naming anatomic parts. So for example, trans men who have not been able to afford having a penis reconstruction are still very dysphoric when it comes to naming their the vagina or vulva. So they may actually use a term front hole. So these are certain things where you ask the patient, what do you refer to this body part, if you have determined that they are transgender. Okay, so these are some of the further reading, and I'm going to be sharing this presentation with the organizers, and I can also upload the file here in the chat on Zoom. So I've given you all hopefully a lot of food for thought. We have about 15 minutes for discussion. So let's do that right now. Thank you.
Thank you so much, sir, for that wonderful presentation. The floor is open for questions now.
Yeah. While we wait for questions, please open the chat box if you want to download the file, which I'm going to upload right now. Assuming I can do that here. Yeah, any questions, please, as I try to do that, please, can the title be placed in the WhatsApp group? Or do you have a WhatsApp group? Okay.
Yes, sir.
Yeah. Okay. What I will do then is I can upload the file in the WhatsApp chat with my point of contact from Palladium India, and you can share it. Okay, so I'll do that as we talk, but we have only some 12 minutes more, so please do ask your questions if you have any. Yeah. Please go ahead. Yeah.
Yes, Lakshana ma'am. All these presentations will be uploaded in the IECO platform.
Yeah. Any questions, any reflections, anything that you thought you knew, but you realized you didn't know? Yeah, Mansi? Yeah.
I'm actually really happy that this happened.
Thank you. Yeah.
Because I think now I'm better prepared to understand how to approach a child or an adult who might have a life-limiting condition. And we think that we know, since just because we have some encounters or we're friends with people from every spectrum, but it's not like that. It's not just, that's not the only helpful thing. This was really helpful. I'm really glad we did it.
Right. Yeah. Thank you for making that observation. And if it makes you feel any better, even within the community, there's not very much understanding. So for example, you can't assume that gay person necessarily knows the struggles or the issues faced by a trans person. Vice versa, a trans person may say the only people with problems are people who look different and others don't have problems. And issues of forced marriage are things that may affect a person who's otherwise invisible. So I think there's a lot of learning to do both within the LGBTIQA communities as well as within the healthcare communities. So thank you for that observation. Any other comments or questions? Sheetal, go ahead. Yeah. Again, we have difficulty hearing you.
Am I audible now, sir?
You are.
Yeah. So thank you for that slide, especially on the suicidal tendencies, that come across, because I was thinking on the same lines, meaning we were having problem because there are teenagers who come in and they don't know what's the problem. They feel all those symptoms were there, feeling not so good about many things, being aloof, depressive, and all those things. So that is also kind of good thing to reflect on, because that was something that comes into mind, probably is it from that perspective. So thank you for throwing some light on that. And I would like to repeat the same request which is put in the chat also, to kindly share more videos and links which we can go through on this topic also. Sure. Thank you again.
I'll do that. There's one question from Mona Verma on chat. just like many government hospitals facilitate many surgeries free of cost, these surgeries can also be done at government hospitals free of cost to facilitate these groups. Very good question, Mona. And actually, within the groups that like gay, lesbian people who are not transgender may not need surgery. Transgender people may need surgery. Some intersex people may need surgery. According to the Government of India Transgender Act, which came out in 2019, every state should have at least one tertiary level hospital offering free gender affirming care for trans people in their state. And they actually gave a deadline of September 22 for every state to comply. But right now, only 2 or 3 states have complied. In Tamil Nadu, there are 2 clinics. In Kerala, they don't have the clinics, but if people go for surgery in the private sector, they get reimbursed up to 5 lakhs. And Chhattisgarh has recently started clinics, but most of the country does not. But the government has also announced that under Ayushman Bharat, if an individual wants a surgery, they can get it covered by the Ayushman Bharat insurance. It's not yet implemented, but there is a policy decision there. Yeah. What I'm going to do is post my WhatsApp number here. So in case you have further questions, feel free to reach out to me. Yeah, we still have 8 minutes. Yeah. Yeah, thanks, Ashley, for your comment. Yeah. Yeah, so I just wanted to know, any of you who have actually been care providers of some kind so far, either in the context of different, like a palliative care situation or any other situation. Have you ever encountered, a situation where the individual was actually distant from or had broken off from their biological family because of being LGBTIQA? Has there been any situation that you have encountered? Because I'd like to know how you dealt with it. Because sometimes you may actually, to protect the patient's rights, you may actually have to limit what you actually disclose to the parents also, because the person may have encountered only harassment and violence all their lives, and they may not want you even to disclose what you know to the parents or to other people in the family. Yeah, Mansi, you have something to share?
I haven't encountered anything personally, but not directly, but in my previous organization where I used to work, Akanksha Foundation, we had this boy who identified as a girl. I mean, he preferred to maybe a trans boy. I'm not very familiar with the terminology, so I'm not going to use those. So he identified as a woman, like to dress like a girl and stuff like that. He did not know, and there was no help available back in the day. So he actually ran away from home and he went to Tamil Nadu somewhere, and he converted. He converted into a hijra. Then he came back to Mumbai and he started working around the roads and asking for money, but soon realized that that's not what he really wanted. He just wanted to, he was not comfortable in his body in terms of just sexuality. I mean, nothing else. So like we as an organization tried to help, but he had gone too far to correct it. And I think he really suffered because of that.
Yeah. So traditionally, a child who's biologically male assigned has that option of running away and joining the Hijra community. A person who, and such a person would be referred to as a trans girl or as trans feminine. So when in doubt, refer to the gender of the person by what gender they prefer. So the child is male, but prefers to be thought of as a girl, refer to the child as she. And but the main point I was trying to make is that this option of running away from home and joining the Hijra community does not exist for trans boys. There are children who are biologically assigned female but who identify as boys, because the parents think of them as girls and they have much less freedom to go away. and leave the home. So many of them are actually forcibly married. Many of them, I mean, there are even fewer options for them than there are for trans women. Yeah, but thank you for sharing that experience. Yeah. So now with over the last 5-10 years, there's a lot of visibility. So there are like groups in almost all states of India. So I'm actually sending you if you orinam.net, it is auto-correcting to origami. I don't know why. Okay. You will find a lot of resources, even for parents, for healthcare providers, etc., in English and Tamil. And I think there are similar resources in other languages. So do check it out if you have more questions. And yeah, if we have no more questions, we can close, but I leave it to our hosts at Pallium India to determine that. Yeah. Do we close? Do we not close?
Any more questions? So, sir, shall we wind up?
Sure. Rachel, feel free to send me a WhatsApp message or an email message. And everyone here is more than welcome to reach out.
Senior, my question is there in chat box. So can you please spare a few minutes and answer that?
Okay, just like many hospice centers for cancer patients, there should be some homes for those who ran away from homes just for not accepting them. Very good point. Actually, the government of India, through the Ministry of Social Justice, has opened some 12 homes, 12 shelters called Garima Graha in different parts of India, specifically for the transgender community. So there are some homes like that. And I think there are homes in, in some 12 states, but we need to have across the country.
Are such homes there in Delhi also?
Yes. In fact, there are 2 homes in Delhi. One is run by Mitra Trust, MITR Trust, and there is another home that is run by Tweet Foundation.
Okay. Thank you, sir.
Sure. The problem is that these homes cannot keep someone who is below 18. So if they are below 18, they need to be sent to the, under the Juvenile Justice Act, there are homes for children in need of care and protection. So they have to go there. But only if they are 18 or above can they go to the trans-specific home.
So as I am tied up with Indian Cancer Society, how about setting some awareness camp about cancer in such homes? As you said, those homes are there in Delhi also.
Yeah, you can definitely do it because a lot of trans people in particular are very afraid to go to healthcare because they've been treated badly in healthcare settings. A lot of basic information, for example, mammography or cervical cancer screening for trans men or lesbians for that matter, it does not happen. So it'll be good if some of these things around detection and prevention are actually shared. Yeah, absolutely. So if you want to reach out and be
so yes,
these homes, you can just Google Tweet Foundation or you can Google Mitra Trust. I will type the 2 names.
As we are having one van for X-rays, ultrasound that rotates all over in Delhi, we just need to give them names. Thank you, sir.
Sure. Sorry, it's Mitra Trust. Yeah. Okay. Yeah. Okay.
Thank you, sir.
Thank you, everyone. Thanks for all your questions and comments and reflections. It was a pleasure interacting with all of you.
Thank you so much, sir. And thank you for all those who joined for this session of FCPC. And being this the last session, I hope you all enjoyed this journey till now. Sinia?
Thank you all for joining us for today's session and for the entire program. Thank you. Special thanks to Ramakrishnan sir for that wonderful session taken out. Thank you all.
Thank you. Bye.
Thank you.